Exciting, right?
Yes. That's one feeling.
Thank you, everyone, for coming. If you could take a seat. If those in the back could find your way to a seat. It's great to have so many people here today, but we still have some seats available. Wonderful. Good afternoon, everyone. I'm Belinda Batten, the Interim Provost and Executive Vice President. Welcome and thank you for joining us for a lecture today by Melissa Cheyney, University Distinguished Professor of Anthropology. Thank you to those of you who are here in person and to those of you who have joined us over the live stream. The accomplishments and impact of a great research university rest squarely on the excellence of its faculty. Those are the people who've chosen to make that institution the place in which to pursue their careers as scholars and educators, and who share in its governance, who work every day to make it an even stronger institution through their leadership and their service. The title of OSU University Distinguished Professor is the highest honor that we grant to our faculty. We've been awarding this title since 1988 to outstanding OSU faculty who have achieved national and/or international stature because of their contributions to research, to teaching, and to service, and whose work has been notably influential in their field of specialization. They represent the very best of our faculty in both the depth and the breadth of their contributions to OSU. Each year we receive a number of excellent nominations for this award, and selecting among them is always difficult. I want to thank the selection committee chaired by Senior Vice Provost Alex Gittleman for their careful and thorough work in evaluating this year's nominees. Following her lecture, we will host a reception right outside this room to celebrate Professor Cheyney's accomplishment. Now I'd like to welcome Philip Williams, Dean of the College of Liberal Arts, who will introduce Professor Cheyney. Thank you, Philip, and thank you all for joining us for Professor Cheyney's lecture.
Thank you, Provost Batten. I first met Professor Cheyney during a meeting with outgoing Provost Fazer and representatives from the OSU Foundation to discuss an initiative of hers to develop a new Center for Excellence focused on community birthing and birth justice. After a round of interviews, Missy let us know that she might have to leave the meeting at some point because she had a client who might go into labor. And in fact, she did receive a text towards the end of that meeting as her client had gone into labor and that she had to attend to her other role as a practicing midwife. Since arriving at Oregon State in 2006 as a new tenure-track assistant professor and a licensed practicing midwife, Missy has established herself as a go-to local, national, and international leader in perinatal care whose engaged scholarship has resulted in improved birth outcomes, especially among minoritized women and those in underserved communities. Her research, widely cited across multiple fields, intervenes in structural, systemic, and social problems of U.S.-based maternity care. As Missy would put it, the United States currently spends around $110 billion annually on hospitalizations related to maternity care, and yet there are 49 nations around the world where it is safer to give birth than the United States. As Missy's research has shown, these problems range from over-medicalization of normal physiological pregnancy and birth to inequitable distribution of care and birth outcomes. Missy also brings her anthropological lens to the global implications of these problems given the outsized influence of U.S. healthcare systems on under-resourced nations around the world. The impact and the influence of her scholarship is far-reaching. What especially stands out to me is Missy's efforts to translate her scholarship to a broader, diverse audience of healthcare professionals, legislators, and community members. That success, in turn, has driven maternal care reform not only in the state of Oregon but nationwide. She shepherded the largest data collection project ever of physiological birth in community settings, home and birth centers in the United States. The National Academies of Science, Engineering, and Medicine selected Missy to help lead its birth settings in America study. Her work as director of the Community Doula Project has been transformative in changing perinatal services and outcomes for BIPOC communities in Benton, Lynn, and Lincoln counties. In addition to her life-changing contributions to research, to policy, and community well-being, Missy is a beloved teacher and mentor, and I see many of her students here today. Thank you. Every day, Missy demonstrates her commitment to changing lives with inspired teaching at all levels, from introductory courses to graduate seminars to mentoring and advising that have garnered a number of teaching awards. Her success in removing structural barriers for students and a record of collaborative research, particularly with BIPOC communities, has made the anthropology graduate program a destination for many BIPOC healthcare professionals interested in adding advanced research to their training. Finally, as the chair of the IRB, Missy brings an equity lens to this high-impact, sensitive leadership position, and in so doing extends her ethos of equity, justice, and ethics to guide Oregon State's research mission. Missy's work embodies the ideals of the OSU land-grant mission. She does life-changing research. She applies the research to bettering the lives of Oregonians. She shares the fruits of her labor through outreach and community engagement across a range of domains, while also excelling as a teacher and a student mentor. I can't think of anyone more deserving of this award. Please welcome join me in welcoming Professor Missy Cheyney.
So much. I'm amazed as I look out to see such a full room that the chair of the IRB could have a draw like this. I really appreciate. I was also thinking I'd be way more comfortable if I were catching a baby right now, but we're going to go ahead. So I am so excited to talk to you about the work that I do in the Uplift Lab. So the Uplift Lab at Oregon State University is a collaboration between the College of Liberal Arts and the College of Health. And I know Marit Boberg is here somewhere. Marit's in the back there. We co-direct the Uplift Lab together. I have no disclosures or conflicts of interest. And let's start with the presentation overview. I'm going to say a little bit about the lab, what we aim to do there, and then I'm going to walk you through just some examples of the local and state level projects, the national work, and then an international research alliance that I work with, just to give you a taste of what we're passionate about in the lab. So the Uplift Lab, we say we explore the ways community-led research, population-level data science, and ethnography can come together to allow us to imagine and implement more equitable reproductive futures. So if we can't imagine a world that's different than the one we're living in, we can't work toward it. We focus on birth justice, birth settings, choice and access, and democratization of knowledge, so making the learnings that we achieve in our lab available to everyone. So when the students that work with me complete their training, they've written a dissertation or a thesis, but they also write a plain language summary that they take back to research participants, and they write a one-page summary that can be used for policy and impact change in the world around us. So why uplift? Let me tell you a little bit about that. So uplift refers to what happens when geese or other birds fly in a V. So when they fly in a V, what happens is the bird that's out front is flapping their wings and pulling hard, and there's a little bit of drift or uplift that's coming back, a boost that's coming back to the other birds. And those birds can kind of rest in that lift and move in unison together with the bird that's out front. But what's really important is that sometimes that bird then has to leave and move around to the back and make space for another bird to come to the front. And so when we come together in our lab, we say instead of embodying an ethic of individuality and look at me and see all the amazing work that I've done, we say we're stronger together. We come together in community, we go further, longer, in a way that's more in sync when we fly alone. And so, of course, I want to show you the fabulous people who I get to fly in unison with every day. These are the fellows, the graduate students that work with me in the Uplift Lab, and they're all sitting right here, being my midwife to my distinguished professor lecturer, which I really appreciate. Okay, so let's talk about our local projects. So I'm going to tell you a little bit about a project called the Community Doula Program. And I say that what we do with that program is we uplift birthing families in Western Oregon. This is a combined project with Heart of the Valley Birth and Beyond, which is a local nonprofit, Oregon State University, and the vast majority of the funding comes from IHN CCO, which is a branch of Samaritan. So this is really exciting. In 2012, Oregon was the first state in the United States to pass legislation that would allow traditional health worker doulas who get on a state registry to be able to receive Medicaid reimbursement. This was really significant because prior to that legislation, the vast majority of people in the United States who had access to doulas were white, middle-class women who could pay out of pocket. So the people whose birth outcomes were so good that they often didn't need the doulas they were able to afford. 8 years after Oregon passed that legislation, 6 white, monolingual, college-educated doulas had made it onto the registry. So while Oregon was at the forefront in legislation, the infrastructures that were needed to be in place to allow people to actually get access to doulas were not there. And this is despite the kind of research that you see here. There's high-level evidence that shows that having a doula who is not a midwife, a doula is someone who provides non-clinical support, so psychological support, social support, and hands-on physical support to someone who is pregnant, in labor, and then in the postpartum period. Just having that person stand alongside you, to be present and to advocate for you through that experience has been shown to dramatically improve outcomes and to reduce the inequities that begin at birth. So the goal for the Community Doula Program was to actually begin to work through each one of those barriers, each one of those steps that it would take to actually connect people who needed doula care to doulas. So we said our goal was to improve maternal and infant health outcomes for pregnant individuals and their families through the provision of culturally and linguistically matched traditional health worker doula services. And I say culturally and linguistically matched because what we meant is that when your doula walked into the room, and I have to say I see so many doulas from our program sitting out here today, that when the patient meets you, they think, I know this person, and this person knows me. They know where I come from, what I care about. They know the language I speak. I don't have to perform in front of them, and I know they're going to be by my side throughout that process. That was our goal. So we set out to recruit, train, and reimburse these culturally and socially diverse birth doulas to serve pregnant members of IHNCCO, so the Medicaid provider, in 5 counties. So our initial goal was to train 30 doulas, and IHNCCO said, we know this is a new program. We're not sure you're going to have 30 people who are actually interested in being on call and serving Medicaid recipients, especially if you don't know you're going to be reimbursed. We had over 100 people sign up for the first training. We've now trained 165 doulas. There are no longer 6 white ladies on the registry. Now there are 68 traditional health workers from our program alone, and 40% of them are doulas of color. Our second aim was to improve birth outcomes and reduce the health inequities that begin at birth through one-on-one support and advocacy. And the next few slides, I'm going to show you what we know about the impact of doula care. And we wanted to offer these services to everyone in our community who qualified. And to date, we've had just over 2,000 referrals. So just enough to be able to tell you a little bit about their impact. And I just want to show you the doulas in the program. Here are some of them. There's a really fabulous video on our website where you can hear them all say, I am a community doula in their first language. So the doulas in our program speak 10 different languages, and we just added American Sign Language, so making that the 11th language. And we've been able to track outcomes for individuals who have a doula and compare those to individuals who are matched for risk factors and demographics or also Medicaid recipients. So the only difference between them is that they have a doula or they don't have a doula. And what we've seen is a really high increase in the rate of breastfeeding. So in Oregon, we have a relatively high rate of breastfeeding initiation among Medicaid recipients. It's about 70%, but if you have a doula, it's 98%. Probably the most surprising outcome is that at 6 weeks, 77% of the people in the program are exclusively breastfeeding. The comparative number is 25% without a doula. And 96% have some breastfeeding at 6 weeks. Our doulas have also played a role in cutting the preterm birth rate. So in the group without doulas, we see about a 9% preterm birth rate. When a doula is present, it drops to 4.1%. And when we single out the communities that are most at risk for preterm birth, Black and Indigenous populations, it goes from 11% to 2%. And all of those preterm births have been preterms that are late preterm, so much closer to being viable, and have been able to avoid being in the NICU. I want to just spend just a minute saying one of our newest findings that I'm really excited to share today is looking at outcomes by primary care providers. So one of the things we've been wondering about is when we see these positive outcomes for doulas, how much of it is the doula and how much of is it the environment that they're giving birth in, whoever their primary care provider is. So what we decided to do is look at two different models. So one model that's obstetrician-led, there are no midwives present at that hospital, and they serve a population that's about equal in risk, a little lower risk than the population at another hospital that has midwife-led care. In that hospital, those midwives do 94% of all the vaginal births. That means the obstetricians are only called for cesareans, for vacuum extractions, or forceps. So they're caring for medically high-risk patients in addition to healthy low-risk patients. And so what we did is looked at what happens when you add a doula to each one of those models. And what we found in the obstetric model is that there was very little movement. In fact, in this particular environment that happens to be somewhat anti-doula, the rate of cesarean birth rose just slightly. It wasn't statistically significant, but it went from 34% to 36%. In the facility where midwives are the predominant providers, the lowest cesarean birth rate ever recorded for a Medicaid population was achieved, so from 24% down to 20%. And I'll just say that as a midwife, when I first saw this, I thought to myself, wait a minute, I don't think I'm doing anything different when a doula's there and when a doula's not there. How are they achieving these outcomes? And what I realized is that was the wrong way to think about it. The right way to think about it is that no one in our country is at risk for getting too much care, for getting too much support, or getting too much love while they're pregnant and while they're giving birth. And midwives and doulas coming together produce some of the best outcomes we've seen, and most importantly, it levels the inequities that we see at the beginning of life. So it reduces and in some cases eradicates inequities that begin at birth. In our doula program, we're not only interested in understanding the impact doulas can have, but also a little bit about their experiences. The doulas in this program transitioned during the pandemic to provide community-based testing for the TRACE program, and were sometimes the only people coming to anyone's home or having contact with people who were giving birth. And so we did an art-based project with them where we asked them to tell us through art and poetry what it felt like to be a doula during such a difficult time in our history. And here I'm highlighting one of the poems from a doula in our program named Jaya, who serves the Mandarin-speaking community. She said, "Birth is a symphony. I know I can leave a birth room when the faces are filled with love. Some have tough journeys, leaving behind something that is sad and blue. Spring birth, renewal, growing and flourishing. The rose petals fall like tears before the milk comes, joy. The layers of being are what we can give. Life is a symphony when you're born with a doula." We had an art exhibit at the Spring Hill Winery, and here's some of the doulas very proudly sitting in front of their artwork. One other thing I'll tell you about the doula program is that in 2022, we were one of 3 programs that were highlighted by a campaign that was funded by Aetna, CVS Drugs, and Every Mother Counts. And they went around and did these little vignettes, they called them chapters, where they talked to doulas, talked to clients in our program, and then made these short little video clips. And when you go into Target and you go to buy a pregnancy test, you'll see a little QR code, and you can scan it on your phone and learn about the benefits of a doula. So now our goal is to connect with other people doing this work along the I-5 corridor and make sure that this kind of culturally aligned care is available to everyone, and then to move from there out into Eastern Oregon, where there's some additional challenges related to rurality, which I'll talk about in just a moment. So now we'll transition to talk about some of the national projects that are going on in our lab, uplifting safety, choice, and respect for all birthing families. And here I'm going to tell you a little bit more about what it was like to serve on the National Academy's Birth Settings in America study. So a little background to this. In 2008, I was appointed to the National Academies for a study session that was commissioned by the U.S. Congress and funded by NIH. we were charged with answering 2 urgent questions. The first one was, how can evidence-informed maternity care systems be designed that allow for multiple safe outcomes across all settings? Whoops. Hold on, give me a second till my cursor gets here, okay. Okay, and how can birth outcomes be improved across and within all birth settings? Now, let me say that we got together for a little over a year, and there were 15 of us from all across the maternity care spectrum. So midwives, service users, physicians, neonatologists, social scientists, and they basically locked us in a room together for 3 days and had us duke it out. We're not supposed to talk about what happened behind those closed doors, but I will say that it ended up being a metaphor for our larger maternity care system. We started out with a lot of differences of opinion and found our way to some really exciting common ground that I'm going to share with you through a lot of struggle, a lot of debate, a lot of argument, but also a lot of mutual respect. And then on February 6, 2020, anybody else remember what was going on that day? It was just the start of the pandemic, but it was also the same day that Trump's first impeachment trial ended in acquittal. That was the day that we went before Congress to present our findings, and I'm going to say we were not the most exciting thing happening that day. So there's been a lot of work that's come after this through grand rounds and publications to try to support institutions to institute some of the conclusions that we found. These are the congresswomen who reached across the aisle, which is no small feat, you know, to actually put this story forward. So this is Lucille Roybal Allard. She is a Democrat from California, and then Jamie Herrera Butler, who's a Republican from Washington. They're the ones that requested funding for this study. And I want to tell you the 5 motivators that were put forward as there was a call for this project. So the question was, why study birth settings using a social justice lens? Using a social lens of any kind. And here are the 3 things that we forward in that report. We wanted people to understand that the United States has among the highest rates of maternal and neonatal mortality and morbidity. So morbidity is poor outcomes, disease, suffering that doesn't result in death, of any high-resource country, and that's particularly among Black and Native American women. Structural racism plays a huge role through implicit and explicit bias in the kinds of discrimination that underlie this persistent racial and ethnic disparities that have been so difficult to change. And there's an urgent need for widespread innovation across all options, which meant that home, birth center, and hospital were all at the table for the first time for the national academies. And then these final ones are that maternal and newborn care in the United States is characterized by broad variation in practice. When you look at outcomes by hospital across the United States, it varies widely. There's a lot of overuse of non-medically indicated care and an underuse of care that we know is beneficial. So there are enormous gaps between practice and evidence. And the United States, as we heard before, continues to outpace all of its peer countries in spending. So spending more than any other high-income nation and yet having some of the worst outcomes. And most importantly, many childbearing people in the United States do not receive the kind of care they want, they need, that they deserve. And that is care that is safe, respectful, evidence-based, and aligned to their actual health needs and preferences. So let me show you what that looks like graphically. This is a disturbing image. What this shows is that in the United States, since 1990, we've seen a 136% increase in maternal mortality, while as all other high-resource countries have seen dramatic declines. That's high-resource and low-resource nations. So the U.S. is going in the wrong direction. It means that it's more dangerous to give birth in the U.S. today than it was in my parents' and in my grandparents' generation. And that's disproportionately born between communities of color. And you can see the lavender and purple graphs here show pregnancy-related mortality for Black and Indigenous communities relative to white communities. And the same trend holds true for the infant. So the dark blue bar at the bottom shows mortality rates by race for babies out to 28 days after birth. And then the lighter blue bar is out to 1 year of life. Let me break this down a little further. My colleague and friend, Eugene DeClercq, who has a website called Birth by Numbers, has broken this down so that we can look at comparable countries that have more than 200,000 births per year and see how we fare. And what's really important to note on this slide is that even if you pull out white, privileged women, their outcomes are still far worse than our next closest nation. And then look what happens when you have the US total. This is an unacceptable situation. One of the things that's most unacceptable to me about this is we actually know what to do, but we lack the political will to walk forward and do what we need to do as a community, as a nation. And here this breaks down for you by state. So you can see that California has some of the best outcomes over there on the far left, and then out to Mississippi. And you can see the US as a whole sits right about there in the middle. Now, some of what we're seeing here is also tied to urban versus rural. So we know we also have significant discrepancies by geographic location. So today in the United States, more than 5 million birthing people live in counties where they do not have access to a midwife, an obstetrician, or a maternity care hospital, which is just amazing to me. And when we look at those mortality rates, what we find is that when you look at maternal mortality in urban regions, it's about 18.2 out of 100,000. When you go to rural areas, that amount goes up to 29.4%. And the same holds true for babies. So a 20% higher rate of mortality in rural communities for babies, and this is exacerbated by race. So there's really powerful intersections between where you live and race, ethnicity that impact whether your baby lives to see their first birthday and whether you survive childbirth. So at the end of our time together, we miraculously came to consensus on 12 recommendations to Congress. There were moments where it did not seem like we were going to agree on one, and we agreed on 3. So the first set have to do with what needs to happen in hospitals, and I'm going to highlight the one here that's really relevant to the work that we do in the lab. So we recognize we need universal quality improvement programs. We need to pilot and evaluate models for payment that are based on value and outcome. But here's my favorite, 7.2, we need to provide greater access to currently underutilized non-surgical maternity care services, vaginal birth after cesarean, doulas, and midwives, or specifically for home and birth center settings. And the recommendation, if you can imagine, coming together across all of those subdisciplines to say that what we need to do is integrate home and birth center settings into regulated maternal and newborn care everywhere in the country, all across all 50 states. It's still a felony in 10 states to give birth outside of the hospital, if you can believe that. Increase access to accreditation for freestanding birth centers in all states, and increase access to all certified nurse midwives, certified professional midwives, all the different kinds of midwives we have in this country that are a result of systemic oppression of midwives by the medical establishment, as long as their education meets the ICM global standards. That's the International Confederation of Midwives, and it's the only set of standards emerging from the global south, and I love that our country was forced to recognize that as the standard for midwifery. And then the almost last set. For everyone, holistic risk assessment, fostering person-shared decision-making, and an increase in access to choice in birth settings. So what I want to say here is that we had a recognition that in the United States today, and actually globally, we have a couple things going on. We have a system that's called a too much, too soon system. That's when you intervene even before anything goes wrong. That's where you come to the hospital and everybody gets the conveyor belt line of $30,000 worth of interventions to get your baby born. And there are risks associated with intervening too much, not the least of which is a very high cesarean birth rate. Cesarean is a surgical method for delivering a baby that's useful in preventing death and suffering in mothers and babies, but when it is overused, it can result in postoperative infections, it can result in nicking of the bladder, the bowel, and all kinds of other issues, including hysterectomy following hemorrhage. So it's nothing that should be taken lightly. So there are poor outcomes that result from doing too much too soon. Poor outcomes also result from doing too little too late. And much of what we can see globally are hospitals that are understaffed, under-resources, and when people arrive at the hospital, There's no one there to take care of them. And because of rampant inequality in the United States and globally, you can have too much too soon and too little too late in the same country, in the same hospital. What we want is to have the right amount at the right time and in the right way. And the right way is a way that respects the dignity of all birthing people and treats every baby as a sentient being. And then finally, we need to ensure levels of payment. In my class today, students were asking me what to do about for-profit medicine. You know, there was just not enough time in class to really answer that. But our maternity care system is operating just as it was planned to operate. We provide the highest quality care to those who can pay and the lowest quality care to those who can't, which is the exact opposite of what we need to be doing as a nation. We need to study and develop sustainable models for safe, effective, and adequately resourced maternity care. And then this last one is saying that we've got to address the inequities that we see. We can't be okay with a country where the color of your skin determines whether you live or die in childbirth. Right after the National Academy's report came out, CMS put out a call for proposal asking what people in the United States, what researchers in the United States think we should do about the maternal health crisis in the US. I was like, great timing, because on the National Academies, you're not allowed to editorialize. This I took as an invitation to editorialize. So what happened is that a group of us got together, so let's see, 6 of us from the National Academies team got together and said, you know, after just having done the National Academies, having read all that research, we're going to tell you what we think you should do. And we put together a report, we put it up on our website, and within a few weeks, all the major midwifery organizations in the world had signed on to it. And then I was invited to present it at the National Institutes of Health Nursing Research Symposium, and I'm going to show you what I said. What I said, and what we said in our report, is this is what it looks like in the United States right now. So this is a hypothetical state, and what we have done is map all the locations where there is currently a hospital. So all those little circles with the H's in them are hospitals. And everyone who lives around those hospitals can get to care in 15 minutes or less, either to the hospital or to a birth center. As you move out into the yellow, now you're 30 to 45 minutes, and then 45 to 60 minutes when you move out into the orange, and then 60 minutes and beyond when you're in the red. And those are maternity care deserts. And this is what it looks like in every state in the United States. And this is why we have 5 million people without care. What if we map the addition of existing birth centers and federally qualified health centers into this situation? So what you can see is what this model has done is add some birth centers in urban areas that are overpopulated, where people come to the hospital and maybe have long wait times or rushed care. And then you also can see some birth centers, and the parameters we used for this was to say place birth centers 45 minutes from a primary care hospital. And what you can see is that there's a significant reduction here in the number of individuals that are in the red and in the orange. But we still have a fair number of people without access to care. And in this model, what we do is we take community-based midwives and we provide care in individual communities. So prenatally, a midwife comes to see you at your house, or you come to a local clinic if you have transportation. You can still give birth in the hospital, but then you return to care in your own community for the postpartum period. And by including in-home community prenatal care, we can provide access to care to all people. What this involves, though, is changing our mindset in the U.S. What we do right now is we try to get people to facilities. So we wrap care around buildings rather than wrapping care around individual. So the care wraps around the person, not the facility, and while a majority will go to the hospital to give birth, everyone else can receive care in their own community. And it's really exciting to say that right now, this Center for Excellence that we're working on in the Uplift Lab is taking all of our learnings from our peer nations and pulling together ideas like this to think about how we can transform maternity care in the U.S. So let me say that when I started my career, I thought, okay, we just need a lot of evidence. And if we get a bunch of evidence and I get up in front of people and give a ton of talks and I'm really compelling, what's going to happen is the maternity care system is going to transform. And then I'm like, well, God, I'm only like 12 years from retiring and this has not happened. So now what I think needs to happen is we need to recognize, and thankfully I'm going to say one of my colleagues, Monica McLemore, who's a powerhouse, is trying to transform hospital births. So I'm like, you go, Monica, you do that. We need to assume this isn't going to change. And what I say is let's build a shadow system that identifies all the cracks and all the spaces where harm is produced in the United States, and we get private donor funding behind filling those cracks. And so a big, big thank you to everyone at the Oregon State Foundation who's been helping help us bring in the gifts that are going to make this possible. We just received funding to do a landscape analysis where we are looking at how we can implement a plan that would make community-based, high-quality, culturally reverent care available in every community in the U.S. in the next 20 years. And Uplift and OSC will serve as an incubator for that idea. All right. Yes, that's worth an applause. All right, so we're going to bring this home by talking about global projects, so uplifting high-quality maternal and newborn care research cross-culturally. So in our lab, we have ethnographic projects in multiple countries. A few of them are Uganda, Ireland, Netherlands, Trinidad, Bangladesh, Suriname. Where's my Suriname friend? She's in the bathroom, of course, but I shouted out for Suriname. New Zealand, Nigeria. And here, this alliance is called the QMNC, the Quality Maternal and Newborn Care Alliance. And this is a global collaboration to improve maternal and newborn health outcomes all over the world. I co-direct this with Holly Kennedy at Yale University School of Nursing. And everything that we do in this project emerges from this. So in 2014, the most comprehensive analysis of the impact of midwives globally was conducted and published in the Lancet series on midwifery. And this whole series, there's 4 articles plus a 5th article that came a few years later, and the summary of this is that midwifery is a vital solution to the challenges of providing high-quality maternal and newborn care for all women and newborn infants in all countries. So these are the articles that were in that. I'm just going to run you through these. I love these articles, and I know you're probably not as interested in them as I am, but I'm going to tell you about them. So the first one did a comprehensive review of the literature and found that there were more than 50 outcomes that could be improved if you just made sure every person had access to a midwife. So if you're a policy person and you're looking for an answer and someone provides you with one like this, I'm thinking, just do that. Turns out it's not quite that simple. The second article used a really complex modeling system to say, what would happen if we did that? What if we gave every person a midwife and on top of that gave them access to family planning? If you give everybody a midwife, 80% of preventable deaths could be averted. If you add family planning, it's closer to 90%. Again, if you're a policy person, you know what you need to do. The next article, the third article in the series, took the 4 low-income countries that had made the most progress in the last 20 years and said, what have they done? Guess what they did? They implemented midwifery in every community across their country. And not only that, it was culturally aligned midwifery care. So midwifery care as a model of care can be adapted to the community that it's serving in so that it's culturally and linguistically aligned to the needs of those communities. What was different about these countries is that they had the political will to put the money towards actually improving the outcomes. And then in the fourth article is a summary and a call to action. And then in that fifth article that came 2 years later, a global survey was conducted to ask researchers, what do we most need to understand to be able to implement these kinds of changes globally? And those resulted in 3 research priorities that I'm also going to share with you. So let's first look at the quality maternal newborn care framework that came out of that first article. Here's the framework. And what this framework shows you is the care that is involved in maternal and newborn care. So what you can see is that down the side, we're looking at practice categories, how to optimize care, the values that guide our work, philosophy, care providers. So this is the whole range of care that people who are pregnant need. And what I did is I put a circle around the aspects of care that all birthing people need. This is education, this is support, this is prenatal surveillance and monitoring, it's support and respect during the birthing period, it's support in the postpartum period, help with breastfeeding. And then in the next piece, what I've done is I've circled the care that only a few people need. And what's in these boxes? You've got first-line management of complications. So birth is natural, but so is death, and midwives want to avert death. And so while most of the time I go to a birth and I catch the baby and I put the baby on the birthing person, sometimes I also have to engage in managing hemorrhage or resuscitating an infant. Those are first-line complications that have to be managed wherever the birth occurs. You're not transferring to a hospital to do those. Those are first-line complications. The smallest box to the next side is medical and obstetric services that only a few people need who have medically complex pregnancies. This is the scope of care of midwifery, the entire box. And this is where 98% of our research funding goes. So the purpose of the Quality Maternal Newborn Care Alliance is to disrupt 2 things. One is research that is focused on the care that only a few women need, and to redirect that research to care that all birthing people need. And the second disruption is to ask, who is producing that knowledge? So we're an alliance of researchers, midwives, and other clinicians, advocates, and policymakers, and we're committed to conducting and promoting research to improve access to quality maternal and newborn care while disrupting current systems of power that shape knowledge production. You know, you can see that a common thread through all these projects is that they're not that ambitious, right? Just a little ambitious. So I'm also the editor-in-chief of a journal called Birth, Issues in Perinatal Care. It's an international journal, high-impact journal. And as I sit in that role and see all the articles that come in and then all the articles that come out to publication, what I can see is that those individuals who are closest to the problem are also closest to the solution, but they're much less likely to get a paper published in my journal. So in anthropology, we have a name for this. It's epistemic injustice. Epistemology is the study of how we know what we know, and epistemology is thinking about who gets to produce knowledge that's considered right, true, accurate, authoritative, and worth acting upon. When we have epistemic justice, we hear more diverse voices. We have a more nuanced and a deeper understanding of how the world works because we're really, truly listening to those who are most affected by maternal and infant health problems globally. And we can be more innovative and effective in our solutions. So I want to show you this. Whose knowledge is produced and reproduced? What you can see in this is a graphic from an article that looked at where the most impactful articles on maternal, newborn, reproductive, and sexual health are coming from, and you can see that the predominance of research is coming out of the US and the UK. Arguably, 2 nations that shouldn't be out at front telling other people how to do it. So what's our vision? We envision a world in which equitable and quality maternal and newborn care for all is advanced through the promotion, conduct, and translation of research that examines the contributions and impact of midwifery. And our mission is to collaborate in global research that promotes, generates, and translates knowledge, particularly of the integral role of midwives in order for women and childbearing families to survive, thrive, and transform. And so what we say is there's been too much focus on not dying in the process. Don't get me wrong, that's good. But to say that you're alive at the end of birth or not injured is really the floor, not the ceiling for what we're aiming for. And we can do better. So how do you do this? How do we collaborate across such a large world to think about and across difference in ways that help promote sustainable models of care? You need Tinder for researchers. And so that's what we did. We produced an online system where you have global researchers who are emerging scholars in low and middle income countries who become part of the platform, and they get paired with mentors who are looking to collaborate with mentees. And what I will say is the thing we learned first is that it's not a mentee-mentor relationship. It's bidirectional. Those individuals on the ground serving every day in countries with the highest burden of maternal and newborn mortality have a lot to say that US and UK researchers need to hear. So we organized around these 3 priorities, which emerged out of that 5th article that I mentioned that came 2 years after the Lancet series in midwifery. The first priority is to investigate the impact of quality maternal and newborn care, and in particular the contribution of midwives, recurrent theme, on outcomes. The second priority is to actually study what physiologic birth is. We have intervened in childbirth so extensively over the last 200 years that we don't even know what the average length of labor is, because we don't allow labor to unfold physiologically. We intervene from the moment the person leaves their home. So can we go back and get an understanding of what's normal and what's not normal, and redirect our resources to intervening only when it is not normal, and allowing the other normal processes to just to unfold as they evolve to unfold. And then the third one is measures and benchmarks. And I love this one. This is the one that I chair. And this is where I'm really curious about finding out from people in communities what they care about measuring. And there's all these benchmarks that come down to us from the CDC and the World Health Organization and various entities. I love finding out what communities want you to know about and what they want to know what's happening in their community. So we determine which indicators, measures, and benchmarks are most valuable for studying quality maternal newborn care, and really centering the views of those who bear children as we think about how to develop those measures and identify any gaps. So we basically all go on this platform every day and talk to each other. The other thing, so we are organized around these work groups. The other thing that we do is we have this thing called Calabash Cafes, and Calabash Cafes are where we get together and we have translation, and we watch movies, we give presentations, and we all sit and talk together. We also have QMNC tracks at events and conferences, and we were also able to get funding to support 7 fellows from the different World Health Organization regions, and to provide them with research management, writing and publication groups, and mentorship and peer support. And so this is a few things showing the success of that. What you can see in this slide is we just hit our 1,000th member. We actually have to upgrade our system because there's so much activity on it, we can't quite function. So what you can see here is the green dot shows where we have the most members, and then the red dot shows lower number of participants, but also kind of gives you the spread. This is number of members, and this is use. And so the U.S. has the most researchers involved, but they have the lowest use. And what we can see is that low and middle income countries around the world are really engaged in this platform and using it to connect with one another to try to de-silo research. And then here's just a quick slide showing where all of our current fellows are coming from. We have a fellow from London, Pakistan, India, Australia, Zambia, Mexico, and Namibia. This was kind of like inheriting 7 postdocs that I hadn't planned on, so I don't totally recommend this, but it's been pretty fruitful. And then the last thing I want to tell you about is that we just got some funding to build an emerging scholars editorial board with mentors. So these scholars will come in, they'll have a chance to be mentored by editors, and their first job is to produce a theme issue that highlights emerging scholars from low and middle income countries that do birth-related research. I'm really excited about that. So my time is up or nearly up. So what I'm going to do is wind down, and I'm going to hope that it is true that pictures speak 1,000 words, and say that what I think the through line is for the work at the Uplift Lab and the work that I feel passionate about is centering those made vulnerable by systems of oppression. This is a Eugene artist named Ela Rose who created this mural, and what it shows is a fat, healthy baby nestled into a caring environment with a healthy ecosystem surrounding it. And this is what my vision is for the United States. Right now, I think we have it exactly opposite. So those who can pay get the highest quality care, and those who cannot don't. If we invert that and center those made vulnerable by systems of oppression, the rest of us will be okay too. Thank you. Thank you to funders too. Just a couple of funder slides.
I want to thank Missy for that incredibly inspiring lecture, but also just sharing a glimpse of the incredible global reach of her engaged scholarship. So we have some time that we're going to kind of shift to a moderated Q&A, and we're going to shift over to the armchairs over there, so bear with us. And hopefully these microphones work. They do? Good.
Yes. They do.
So we had some pre-submitted questions, and we're going to start with a couple of those, and then we're going to open it up to the audience and toggle back and forth if you don't have too many questions, but I think there will be. So the first question, I don't know if it's a softball or not. There's a lot of ways to think about this, but who has been the biggest inspiration in your work?
Audre Lorde. 100%. So a couple years ago, a colleague of mine named Jonathan Snowden, we got a fellowship from Oregon Health Sciences University, and the fellowship said, what we want you to do is think about anti-racism in the academy. There were no restrictions. We were able to come together with a couple of graduate students, 4 graduate students, and have these weekly meetings where we centered the work of Audre Lorde, and we said, we took at its foundation a couple of things like poetry is not a luxury. So we tried to really break down the differences and the ways of thinking between science and art, and to think across epidemiology and anthropology. And we produced these really interesting outputs that have really inspired me. One of them is we got a poem published where we wrote about who we were and what we brought to the work. And it's this really interesting mix of citing various theoreticians and scientists, and then also a lot about who we are as people. And that was in a public health journal that was trying to kind of break down silos between art and science. But I think the most impactful work that we did is we centered the work of Audre Lorde in thinking about what the academy could be. So we took the idea of the undercommons. Anybody know about this? Because I'm forgetting the author's name. Look out for me. Google it. Oops, there's my alarm to stop talking. So the undercommons happens at universities where, we have the day-to-day work of going about our classes. In the undercommons, it's where we all get together and scheme about how we want to make the world a better place. Like, we see these social levers that we want to move, these types of inequality that we want to address, and you kind of meet in the undercommons to scheme on how you're going to do that. So we produced a graphic novel that has students in the Uplift Lab finding the undercommons, getting together in the undercommons, and then working together to think about how they can imagine more equitable birth futures. And Audre Lorde is her poetry is woven all through that book. Yeah.
Thank you. There was a question kind of about our current national landscape. I don't know.
Oh dear.
In the light of our current national landscape and the policies of the federal administration, what do you see as the most promising opportunities for advancing reproductive health initiatives?
Wow. The most promising. Whoever came up with that question, I think before I say that, I'm going to say, like, this is a really hard time to be doing the work that I am doing. For so much of my career, it felt kind of like an uphill battle. And over the last 5 or 6 years, as sort of the issues that we're dealing with in maternity care in the U.S. have gotten into popular consciousness, you can see them in the popular media. I had this thought, like, we're going to go somewhere. This is amazing. This is exciting. And I think the first part of 2025 was thinking, like, okay, maybe that's not where we're going right now. But I will tell you what inspires me, and that is, in all of those projects that I work on, there are staff members, there are doulas, there are midwives who are engaging in those projects, and they will not be stopped. They are propelled by wanting a better world for their kids. And no matter what you throw at them, they're up every morning ready to go. And I'm betting on them. 100%.
Thank you. This looks like a question maybe from a student. From different disciplinary perspectives, how do you approach studying the interaction between human biology and culture when analyzing health disparities across different populations?
I love this question. Okay, so the approach that I use in my work is called the new biocultural synthesis, and what it argues is that if we want to understand any aspect of health, there's 3 things we have to think about. One is evolved biology, the other is culture, and then the third is power dynamics, and that is so relevant in my field. If we want to ask, why do outcomes look the way they do in the United States around birth, when I think about evolutionary explanations, we're all bipedal. We walk upright, and walking upright has caused a transformation in the kind of pelvis that we have, so that humans have really difficult births. Like, if you don't believe me, you come to a few births with me, okay? The head is literally bigger than the pelvis, and the baby has to go through all these twists and turns to navigate a pelvis to be born. And so many millions of years ago, humans and human ancestors evolved to have access to a helper at birth. So one of the kind of first evolutionary adaptations that sets humans apart is something we call obligate midwifery. And as humans have these really complex birth mechanisms, almost every culture has somebody with you at birth. So when you go into labor, you reach out to someone who you feel comfortable with, who you feel safe with, and this hormonal milieu that happens between those 2 individuals is what enables the birth to occur. So our cortisol levels go down, our oxytocin levels go up, we get these hard contractions, and the baby is born. So deep in our DNA is this evolutionary pressure to have that kind of social support at birth, and yet our culture vastly underestimates the evolved psychosocial needs of people who are giving birth. And we think that we can improve outcomes by only focusing on the clinical side. And the biological aspects show that that is not true. Certainly cross-culturally, I've gotten to attend births in lots of different countries. And while many of the aspects are similar and recognizable across cultural groups, the meaning that people attach and the way they culturally and ritually elaborate birth is dramatically different in different places. And it's such an important part of how new people are made, right? Because they're not just being made biologically, they're being made culturally and socially. So where you're born, how you're born, the first words that are whispered in your ear, who catches you when you're born all matters in creating humans. And then my whole talk was about power dynamics, so I don't have to say anything else about that. Clearly, that is at play here. And I just want to make sure that we all leave understanding that it is not race that makes people have poor outcomes, it's racism. So let's be clear on that.
We're going to open it up for questions from the audience. We have microphones on both sides, and we'll intersperse some other pre-submitted questions as well. So those of you who have questions, if you want to come forward.
Oh, dear.
What? No, I'm very curious about the spread of U.S. or Western medical practices across the world and how that's changing or has changed over the years.
Yes. So this is an excellent question. So one of the things that is most surprising, or was most surprising to me as a young anthropologist traveling around the world, is the degree to which U.S.-style biomedicine is hegemonic, meaning ruled by cultural consent. So many of the places where I attend births, what I see is people adopting pieces of what we do in the United States and thinking of that as normative. And I'm going to tell you that if you put $110 billion behind it and it doesn't work here, it is not going to work in sub-Saharan Africa where you have very, very limited resources. And a lot of what I see is the danger, the harm, even the death that results from attempting to emulate a country that hasn't really earned the right to be emulated. And that's part of why I work in the U.S. You know, anthropologists typically work outside of the U.S., but I think there's a lot that can be learned by turning the critical lens inward and thinking about what we do that works and what doesn't work. And, you know, there are some really amazing things about the U.S. maternity care system and some of the innovations that we have developed in terms of managing preterm birth or caring for preterm infants, the way that we can deliver cesarean care for people who really need it in ways that minimize pain and suffering after the birth. A cesarean looks really different in a low-income setting than it does here. And so there's some really valuable things about it. But what we've lost and what we can learn if we can set down our U.S. exceptionalism a little bit is the importance of the cultural and the ritualistic aspects of how important it is to treat birth as a rite of passage. And that's something that we would do well to learn from others on. When I was on the National Academies, one of the things that was really interesting about our project is that Congress said you will also do an evaluation of peer nations. And so you'll evaluate your peer nations and you'll learn from them what they do that is different from what you do and what take-home messages you can take from that. And honestly, there were a couple people on our committee who was like, I don't know why we would do that. We're the United States. Why would we look at any other healthcare system? And I thought, that is really to your detriment. Because many, many, many places around the world have a lot that we have to learn, that they've already figured out.
I guess sort of following up on that question, the adoption of U.S. medical practices, do you see it, is it through medical training that's being received? Is it through aid agencies? Where is all that coming from?
Yeah, it is really all of the above, and so it has to do largely with funding. And so, you know, I can give you one example. So in our country, in the United States, we deeply underutilize midwives. So if you look at, you know, when we did that peer nation analysis, one of the things that we learned is that how other nations who have socialized medicine, how they manage that is when you get pregnant, you go to your midwife. And if you develop a medical complexity, you will, of course, triage up to a higher level of care, and you will right-size your care to the type of provider. But you're not going to have a healthy, low-risk person with no complications go to an obstetrician. And sometimes when I put up a slide that says, you know, 90% of births in the U.S. are attended by obstetricians and 10% are attended by midwives, someone in the audience will say, oh, you have your slide reversed. And I'll say, no, I don't. And they'll say, well, if that were true, your system would be horribly expensive and your outcomes would be horrible. And I say, yes, right, exactly. That's what I'm trying to say. So, so that is one of the things that happens is that as you start to think of the U.S. as a cultural leader, and I can't tell you how many like low-income clinics I've been in who have like a full set of like the Green Journal. So we also take our journals and we spread them around the country, spread them around the world so that people have access to this research, but none of the resources to implement what is in there. And so there's a kind of colonialism that is happening that is very overt, but there's also kind of an internal colonialism, a colonialism of the mind, where many of the people I work with have sort of internalized the idea that we're somehow doing it better. And it's very detrimental.
Other questions? For those of you who didn't hear, the question was, what's so threatening about midwifery?
I ask myself this a lot because I am so lucky that I live and work in a community where we have really midwife-led systems. And so I get to see every day how we have home birth and birth center birth, and we have midwife-led care in our hospital. And it really works out for almost everyone. A lot of the obstetricians and gynecologists I work with love that they're not up all night and that they're not on call all the time. And that when they are called in, they're called into work at the top of their license to intervene as surgical specialists the way that they're trained. And I actually see it working out really smoothly. It's kind of like a win-win for everyone. But when midwifery is first proposed in places, I think this is something that comes with for-profit medicine. There's a lot of territoriality and a worry that somehow you'll be displaced by someone else. And, there's good reason to worry about that. In New Zealand, the New Zealand government said what we should do is let birthing people choose who they want to be their lead maternity provider. And the physicians were really behind that because they really believed that when you gave people the choice, everyone would choose a physician. And what we have seen is the opposite was true, that everyone chose a midwife. And in New Zealand, it is your basic human right to have a midwife. So even if you're going to have a planned cesarean, you'll have a midwife by your side because it's everyone's right. And I think this goes a long way to saying, most of us, when we're experiencing the kind of vulnerabilities that you feel when you're pregnant and in labor and, maybe not sure of what's coming for you, you do want someone by your side who you feel actually cares for you. And I think we can't underestimate the relational aspects of medicine and think that the sort of high-tech system we have produced that replaces the high-touch systems that we see in other cultures are going to be enough. We need a combination of those things.
I think there was a question over here. Do you want to go up to the microphone, please?
Oh, it's also misogyny. I didn't say that. Yeah, that was the other part. Yeah.
Hello. Oh. So I'm just curious, based on your interactions with biomedical practitioners in the U.S., so I guess MD, DO physicians.
Yeah.
What have you kind of observed about if there's a common attitude or sentiment towards alternative birthing practices, and if that falls more at the personal level with them, or if it's more structural or institutional?
Yeah, that's a great question. So one of the things that I do that I really love doing is there's an American Medical Student Association, and they have a reproductive justice series, and they always ask me to come and talk, and I get so much hope out of talking to those students. I really think that the current generation that is in school to become obstetricians and gynecologists have a much stronger sense of these things and have kind of grown up understanding the reality that when the origins of poor health are social, that the solutions need to be too. And so they're much better trained in thinking about the social determinants of health and much more aware of their own biases. And so I feel like a lot of hope going forward. I also think that that the vast majority of the obstetricians I know and work closely with, because most of my work, if not all of my work, is collaborative with physicians, is that if you can get together and put some data at the center of the conversation instead of having fear be at the center of the conversation, you actually can get quite a long way in finding common ground. And, I think about, a long time ago, it must be 20 years ago now, I transferred a planned home birth to a hospital in Eugene, and I was received by a physician there. I'm his kid's godmother now. We grew from knowing each other and learned how to speak across our differences and to find ways to collaborate to get the right amount at the right time in the right way. So I have a lot of hope that that's going to happen in our next generation. I also say, I really love working with very old physicians because they've been around for a long time and they've seen how everything changes. They're not so married to this is how you have to do it. And so oftentimes I'm pretty excited when I see a physician that's been around for a while and has probably had some time to work with a midwife. But overall, I feel really optimistic about where our med students are going.
Dwayne. All right. Thank you, Misty. Is this on? It is on. Okay. So my comment really is about an observation I've been making for the last decade or so, and that is with U.S. policy around control of women's bodies. And so as we watch what took place with the striking down of Roe versus Wade, I then look at that through the lens of race, like you've done so often. And what I see happening there, of course, is that these policies are really directed towards white women. They're not directed towards women of color. People would actually like to sterilize those women, but they would like to make sure that they actually have control of white women's bodies, so they're constantly reproducing the next generation. We saw this happening in World War II. Nazi Germany tried to do the exact same thing around encouraging white German women, to only reproduce for the fatherland. And I'm seeing the same kind of rhetoric, the same kind of conversation going on here in the United States in ways that are very, detrimental. I wonder if you can comment on that.
I can. I will say that, it is really concerning to see some of these pro-natalist policies and where they are focused. I will give you an example from my work that I think really illustrates what you're saying. When we talk about family planning, what we often mean is making sure that wealthy white women who fit a certain stereotype are the ones that are reproducing, and it's about controlling and preventing reproduction in others. We were talking about this in class today, and students were asking about policies to provide long-acting birth control or sterilization to people who've had more than one baby taken away in relinquishment, and what I thought about that. And what I can say is that it is, my work comes from a reproductive justice framework, which is what I was showing in that picture, which says we all should have the right to have the number of babies we want, when we want them, how we want to have them, and we should have the right to grow them up in a healthy society. And I think that needs to be for all people. And yet we often have that only for a small segment of the population. Where I really ran into this in my own work is doing some work in Puerto Rico. And so one of my grad students and I have been trying to understand the role of stress on preterm birth in Puerto Rico because they have a very high rate of it. So we did a project where we looked at hair cortisol in the mother to try to get a sense of the role that stress was playing in producing these outcomes. Now, right in the middle of that work, Zika became a thing. And so we had funding from the National Science Foundation, and they said, if you add a couple Zika questions to your research and start exploring Zika, we'll give you more money. So we said, okay, well, we'll do that. And because we were curious, but also because they gave us more money. And what we really learned is how challenging it is to give public health advice in a community that has a history of forced sterilization. So here's what we heard from everybody. The CDC says that our babies might be born with microcephaly if we get Zika, and you can't know if you've had Zika or not, so just don't have any babies for the next several years. And you know what our community partners said? They said, we don't believe it. We have mosquito-borne disease all over this island. You just don't want us to reproduce. So you have babies then born Zika affected with microcephaly. And one of those people I worked with actually said out loud, well, if you have to have microcephaly, it's better that it be in Puerto Rico because they have extended families so they can help take care of the babies. That should be your inside voice, right? You don't say that. out loud. And so I think this sort of pro-natalist meets eugenics, racism, produces all kinds of dilemmas that we will be paying the price for going forward.
Yeah, come on up.
Thank you so much for. Is this on? I don't know.
A little bit, yeah.
Hear me? I'm right here.
Because you're right there.
Thank you so much for your talk. I'm in the anthropology program, and I'm sure all the students are so proud. I am. Like, to have such an amazing mentor, and not only you, Missy, but our entire faculty. It's amazing. I will go back a little bit to a topic that you were talking before, but I'm curious if you think the model that your lab is working with regarding like the socialization right of birth and midwifery could be applied to other fields of medicine as well. Not only to pregnant people, but do you see this model with, be applied to other kinds of diseases, for example, other groups of people, etc.? I'm just curious. It seems such a powerful and it offers such a positive result, what you are doing, that I'm wondering if that can be applied to other sectors as well within medicine. Thank you.
Yes, so that's a great question. So can this approach, this sort of biocultural approach, can it be applied to other aspects and not just maternity care? And the answer is yes. And if you have a chance to go look at the website and see some of the work that's happening in the lab, there are students in the lab that are applying it to end of life and thinking about how we have over-medicalized death and dying in our culture, where people can endure extraordinary levels of suffering in the hopes of extending life for a short period of time. So that is certainly the case. There's also a student in our lab who is looking at a biocultural approach to understanding really young children, so doing ethnography with 3- and 4-year-olds to understand how they experience stress in their day as they move through their time in preschool. So yes, I think it can be applied across all fields of medicine.
It's working now. First of all, thank you so much for this talk. It's been amazing. So as you remember, Ruha Benjamin was here in January, and I'm reading Imagination, a manifesto. Highly recommend. And I think a lot about the imaginary and this moment we're in, where world building and world making exercises are so important. And you said in your talk, if you can't imagine an equitable future, how can you implement an equitable future? And of course you brought in Audre Lorde. I wonder if you could speak more to the place of imagination right now in our work, and that could be whether you're talking about your classes right now, or how your students are helping you to co-create this sense of imagination.
Yeah,
Thank
absolutely.
you.
Thank you. That's a great question. So when you asked me about who influences me, and I said Audre Lorde, I was also thinking Octavia Butler is up there. I'm thinking of The Parable of the Sower, Kindred, and then there was just a group of short stories that was dedicated to her, where the authors, the editors asked people to write about what our world could look like in the future. And it was amazing to see what people came up with when you kind of removed those boundaries to think of what it could be like. So there's a couple ways that I think we think about it. Part of it is that a lot of the people that work in my lab are really interested in using arts-based approaches and also ethnographic fiction. So moving away from sort of the standard approaches not moving away, but not an or. Using ethnographic approaches, qualitative, quantitative, but then also using art as a way of exploring what the future could look like, and thinking in this aspirational way about the kind of world that we want to live in. So I feel like there's a lot of promise in arts-based approaches to enable people to think outside the constraints of what we have now. The other thing is, I think we in our lab try to create amongst ourselves a way of working together in a space where we work together that transcends into the classroom, that would be like we would want the academy to be. So when I hear, some of my students say, I don't want to go on in the academy, it's too stressful, it's, there's all kinds of things, it's elitist and whatnot. I also sometimes think, well, the academy is what we make it, right? We're the academy. So we want to use imagination to think about different ways that we can actually work together and provide these kind of supports. And I feel very inspired by the people I work with and how they uplift each other. And with those kinds of permissions, it's amazing to see the kind of collaborative work that can come out of it instead of the, sort of the competitiveness that sometimes characterizes the academy. So I take a lot of inspiration from Afrofuturism and science fiction and think about, what things could look like. And so I often spend a lot of time imagining like what it would look like if I was like super successful in my work, if the way I imagine the world working, if it came to pass, what that would look like. And I often find myself kind of explaining it to my students. I know I did that today, and they were all kind of like, whoa, what's she doing over there? But, I talked about the radical idea that we would approach people with substance use disorder who are pregnant with love and compassion and an open door to seek out recovery instead of with, let's get you sterilized as quickly as possible, and what that could look like. It was fun to see the questions that they asked and the ways they started to think about what a future could look like that maybe isn't constrained by what we have today. So this is the place to do it, right? Where we all have the time to get together and talk and think. Yeah.
We have time for about one more question. If not, there was a question actually that was submitted about the kind of the impact that you have on your students. Probably best
like
answered by your students, but I will read this. With the majority of your work being centered around issues surrounding access to equitable birthing options and normal physiologic birth, can you please expand on you've expanded on your full research portfolio, but how that has impacted and influenced the students you mentor? And what are some of your former students doing out there in the world today?
Oh, I love this question. Okay, so let me just say, I don't know how I impact them. I can tell you how they impact me. And I every day think we really are all teachers and learners. Like every moment that I interact with them, they're encouraging me to think about the world in a different way. And that's what makes me love teaching. It's true for undergrads too, not just the grad students. Especially in the field of health, like we all live in bodies that have experienced poor health, that have experienced what it feels like to be healthy and well. We've all had positive encounters with care providers. We've had negative encounters. And so people come to my class with a ton of lived experience and a ton of expertise. And I really feel like I'm learning as much as they are in the relationship. I'm amazed at how successful my students are. I joke about it and I say, I'm kind of selective about who I bring into the program because I have 100% perfect record of them all getting amazing jobs in their field. So don't come into the lab if you're going to mess that up, right? Because we want to have that be 100%. I also joke with my undergrads and say I have 100% acceptance rate to med school. So don't ask me to write for you if you don't think you're going to get in because you're really successful. But I actually think maybe one of the things that I have to offer them is a lot of the students that come to work with me are healthcare practitioners of some kind. They're midwives, they're doulas, there's 2 physicians who work in our lab, they're lactation consultants, or they're students who are going to be doctors someday. And I always say, you go through your pre-med program and, that's going to teach you how to be a doctor. But you come to anthropology to learn how to be a healer. And that's what's different. And I think that all of the students that leave my lab and go out into the world are healers. Now, they're in the academy, they're in nonprofit work, they're in government work. They're literally everywhere. Whenever I get on a call, there is invariably a student in there, and then the other students are like, what? How many students have you had? And they're everywhere. And I feel really positive about that because when I retire in 12 and a half years and teach yoga, they're the ones that are going to be solving all of these problems that...
A date in mind, obviously.
I know exactly when it's coming.
Well, I think that's a great place to leave it. And if all of us don't want to sign up for Missy's classes after this, I don't know what's wrong with you. But I want to thank all of you on behalf of Provost Batten and myself for joining us for our new University Distinguished Professor, Missy Cheyney's lecture. And we invite all of you to join us for a reception to celebrate her many accomplishments. Thank you all.